we might as well just do the lectures, okay? And so the lecture today is about kidney stones. I feel like a lot of people know about kidney stones, especially, you know, how it's present. But I feel like step one doesn't really test, you know, relevant information about kidney stones. The information they test you is more about what kind of stones they are, versus, you know, how you treat a kidney stone and what symptom do they usually present with. Okay, so we're just going to do a quick one. All right, so let's see. So first, I want to do a quick, you know, the basic information about, you know, kidney stones. I want to see how many of you guys know about kidney stone, okay? I'm sorry, I screamed a lot when I watched the match last night, so my voice kind of, you know, I'm losing my voice. So, all right, so anyone tell me where are the kidneys in the body and what's the function of the kidney? Okay, I'm gonna pick one, Phương Thảo, let's give it a try. This is the time that you guys have to practice your English. So you know, just talk.
Yes.
Okay. Tell me where are the kidneys located in the body and the function of the kidney.
Kidney is location
Where are the kidneys? Just tell me you know, how do you find the kidneys?
a pelvis.
Pelvis is a little bit too low. So usually where would you find the kidneys on a human body's like approximation? All right, let's see, let's look at the lung first, okay? So is it below the lung, right? So what below? Okay, so the lungs, right? So you have the right and the left lungs, and you have the liver, and then on the other side you have the spleen, right?
Yes.
And then next to them should be the kidneys.
Yes.
Okay, so kidneys are considered to be a retroperitoneal organs. You know what that mean?
Yes.
Okay, all right, and do you know what's the function of the kidneys?
The functions of kidney is
what does a kidney make? What fluid does a kidney make? All right.
I can't describe by English.
Okay. All right. You can speak in Vietnamese. It's fine for this time. Okay. So, so cái thẳng của mình làm cái gì?
Dạ, thứ nhất là chức năng thận là có các chức năng lọc.
Lọc cái gì?
Lọc máu.
Okay. So filter the blood, right?
Yes.
Okay. And what's the other functions?
Thứ hai nữa là
So once you filter the blood, what do you make? Khi mình lọc cái máu rồi á, thì nó thường ra cái gì? Lọc máu ra cái gì?
Thì nó sẽ được đào thải những cái chất không thân thể trong cơ thể, ví dụ như là có thể đào thải ra những cái chất điện giải hoặc là muối.
Okay. Yeah. So what's left over? So cái phần còn lại là ra cái nước gì?
Tiểu.
Yeah. So yeah, exactly. So filter the blood and then make the urine, right?
Yes.
Yeah. So I'm trying to you know, teach you a little bit English. I know that, you know, a lot of you guys do have trouble with English. So if you don't know how to speak in English, just speak in Vietnamese, and then I will try to translate it to English so you guys can learn. Okay. So yeah. All right. So you're right. So the function of the kidney is basically to filter the blood, but they usually the anatomical position of the kidney is usually below the ribs. So that's why sometimes when you have you know, rib fractures can actually puncture either the spleen and also the kidney also. So because it's very close to the ribs. The function is to filter the waste and also to produce urine. So basically we make about 2 liters of waste products in urine. So that's why when you have a patient have kidney stone, you want them to drink about 2 liters of water to basically to replace the water loss that they have. Okay. All right. So the next question is, what is a kidney stone? All right. So I'm going to have my Hello, Mai?
Hello.
Yeah, what is a kidney stone exactly?
The kidney stone is the stone that form in the urine tract.
Okay. Yeah, no, that's easy enough. I mean, you know, so there's 3 answer choice. I want you to pick one. A, B, C, D.
Okay. I'm gonna pick A.
Okay.
Hard.
Yeah. Yeah. All right. So since the question is so easy, I'm gonna ask you the next question. Okay. So what's the most common symptoms when patient come in with a kidney stone? Anyone?
Hello.
Yeah. Go ahead.
It's not multiple choice.
No, it's not. So these are, you know, just common questions. There's no need for no multiple choice.
It's colicky blank pain.
Okay. So when you say colicky, what does that mean?
It's the pain is appear as episode.
So when someone say colicky, I mean it comes and go. Can someone come in with a really sharp pain and a constant? Can it still be kidney stone?
Sorry, can you repeat the question?
So if someone come in with really sharp pain, you know, like đau nhói, right? And then it's constant, like it's lasts for, you know, 15 minutes to 20 minutes. Can you still think that's a kidney stone or not? Or it has to be a colicky?
Yes. You still have to think about the kidney stone. To try the symptoms.
Okay.
Yeah.
All right. I'm going to ask you the question later. Okay. So how does a kidney stone cause pain? But that's for later. So you're right. It could be a sharp pain or it could be a colicky pain. It really depends on where's the location of the stone and you know how long the stone gets stuck in there. And sometimes you can actually have fever and nausea. If you have fever, which means that you know you might have some sort of infections or inflammations that irritate the area around it. But most common is also blood in the urine. So when someone comes with blood in the urine, first thing you can think about is kidney stone, and then after that you can think about the more serious problem like you know cancer, bladder cancer, or other things. All right. So which condition or dietary habits are thought to be among the more likely cause of the formation of stone? So is that A, is that B, is that C? All right. So I'm gonna pick someone who just came in. Let's see. Nhật Ngô. Oh. All right. Let's see. Phương. Is that Phương Vy? Yeah.
I think both of the above.
Okay. All right. So why you pick both the above?
Oh. No, I think I can choose.
Okay, so you think A is correct, right?
Yes.
Yeah, most of the time, like we tell the patient that you gotta drink more water, right? Why is that drinking more water would help you with the kidney stone? Okay, so we will talk a little bit more about formation of the stone later. So eating too little fibers is usually doesn't really help with kidney stone at all. It's more of you know like constipations. So this is just trick questions, but so those are the answer. Eating too fibers have nothing to do with the kidney stone. Okay, so sometimes when people put like both of the above, it doesn't mean that probably the answer. Yeah, you fall into the trap. Okay, all right. So what is the most common treatment for kidney stone? Is that drinking a lot of water, medications, or surgery? Have you seen anyone with a kidney stone in Vietnam? What do they usually do?
I think they do the surgery.
Okay, yeah. What kind of surgery?
Phẫu thuật nội soi.
Okay. Okay, it's phẫu thuật nội soi. So how do you say that phẫu thuật nội soi in English?
I think
okay.
I know the word, but I forgot it.
Okay. So anything with nội soi, I mean, you need a endoscope, right? Yeah. So anything with nội soi is an endoscope. So endo, a scope means that's a camera that they use, right? So endo is basically nội soi. All right. All right. So this objective for the lecture today is just basically understand the general structures of the renal system. Basically, we need to know the anatomy of the system before we talk about the stone. And then after that, we talk about different type of the kidney stones and their causes, and usually symptoms, diagnosis, and treatment of the kidney stones. And then we can do some practice question about the kidney stone. Okay. So first, we talk about the anatomy of the kidneys. So anyone, sort of walks me through the kidney stone, the kidney a little bit. So when we talk about the kidney, we have to think about the structures. So first, we have this. So we have the cortex of the kidney. So first, we have the capsule. All right, let me do this thing right here. So right here. So this is the capsule, which is a thick, basically for protection of the kidney. And then we have the cortex, which is the middle part over here. This is where all of the blood vessels are running through, and also where all the electrolytes and things are being absorbed into the blood vessel. And then everything's being reabsorbed and filtered. And then we go to this renal calyces. So we call these the renal calyces. And when it's dumped into here, it would go to a bigger, basically collecting system. So we call it the renal pelvis. This is the bigger one. So we have the renal calyces, which is the smaller one, and it go into the bigger one, and then it dump out into the ureter. So step one would test you basically the blood vessel within the renal system. So when you think of the renal artery, you think about L1 level of the spine. So we think of renal artery, which is a L1 level. And then the renal vein is usually passed in front of the renal artery and the aorta. Usually that helps when you look at the CT scan. And what I want you to know is the renal blood flow. So how does the blood go from the kidney, being filtered and being reabsorbed back into the vein, the venous system. So we have the renal artery. The blood would come in here first. Okay, so we go to the big renal artery, and then it would go into the segmental. We call segmental because it starts to become a segment. So anything it called segmental means that it's a smaller piece. So we have the bigger artery, and it become a segment, which is a smaller. And then we have the interlobar artery. They call it interlobar. You think about lobar. Lobar means there's a lobes. So the kidney, you can divide it into like different lobes. So this is one lobe. This is another lobe. This is another lobe. So that's why it called interlobar. And then it go into the arcuate. Arcuate means that it's basically anything that kind of like an arch. Like bắn cung, right? So this is an arch. Right, so that's why we call it an arcuate. So like archer is also start with an arch. So if you study mathematics, arch means like it's like a an angle. So that's why it's an arch. That's why we call this artery is an like an arcuate artery. And then we have to understand the afferent. You need to know afferent and efferent. So the way that it helps us remember afferent versus efferent is that anything that arrive in, so the blood arriving to the glomerulus is called the afferent. So A with A, and then efferent, basically even accident. So you have a glomerulus just like this, and then you have the blood vessel come in. So this is the afferent, and then one is filter the blood out, and then it accident the glomerulus. Then we call this is the efferent. Okay, so this venous system then go through, the vasa recta and the peritubular capillaries, which you probably don't need to know about, but you need to know is the afferent, go into the glomerulus, and leaving the glomerulus is the efferent. Okay, all right, and then after that, Let's see. And then we need to know the anatomy. So what more important is that you need to know the structures, the anatomy on the CT scan, because this is most likely what they're going to ask you, okay? So I'm going to pick one of you guys, and I'm going to use the thing to point, and you tell me what it is, okay? So you're going to go first. Okay, so tell me what this is. What is this one?
It's a blind.
Okay, so when you read a CT scan, this is CT scan, right? So if it's over here, what side is this? Is it left side or the right side?
Oh no, I'm sorry.
Okay.
It's the right side.
Okay, so this is the right side. So imagine that you are looking at the patients. Imagine that, you know, they're looking from the feet up, okay? So this is the feet over here. This is the feet, okay? This is the head, all right? So this is the right side, okay? So what's on the right side?
Yeah, probably liver.
Yep, right, exactly. So this is the liver, okay? All right, so now I'm gonna pick, let's see, Phương Vy. Tell me what this is.
So in the back.
Mm-hmm. Tell me what is this organ right here that I just circled?
Sorry,
All right, so first tell me what side are we looking at? Is it the left side or the right side of the patient?
Những cái đường truyền của em bị chậm.
Gì? Nói gì?
Dạ, cái đường truyền của em nó bị chậm hay sao?
Ok. So có thấy là mình vẽ ở trong cái hình không?
Dạ, thấy được cái vẽ được cái cái hình nằm ngang.
Ok.
Cái hình đỏ nằm ngang.
Yeah. So cái này á, là bên trái hay bên phải? So this is it on the left side or the right side of the patient?
Vậy là cái hình màu đỏ anh mới vẽ hồi nãy là bên phải.
Okay. So this one, can you guys see my mouse, right? Can you guys see it?
Yes.
Okay. So what is this organ here? Is it on the left side or the right side of the patient? So if you look from the feet up, right? This is gonna be on the left side, right? Okay. So what organ is a really long piece of organ that run in the left side? Think about it.
The pancreas.
Yes, exactly. I think we talked about it last time. It's a pancreas, right? Okay. And all right, good job. You know, that's pretty good. All right, I'm gonna mute you, and then I'm gonna ask another one. Yong. All right, I'm gonna pick you. Tell me what this organ is. This one, right here.
It's maybe ascending colon.
No? Okay. So how do you know it's ascending or, well, you know it's a colon, okay? That's all I need from you. Okay. So that's easy. All right. Then what about this one?
It's a right kidney.
Okay. This one?
Kidney.
What about this thing with the bright color in it? What is this?
Ureter. Dry ureter.
Are you sure it's a ureter? So why is it bright?
It's a liver.
What makes it bright?
Yes. What?
Yeah. What makes it so bright? Tại sao nó sáng vậy?
Maybe it's a.
What is the thing that you inject the patient with before the CT scan?
Thuốc cản quang.
Okay. Yeah.
Yes.
So thuốc cản quang nó làm cái màu trắng, right? So thuốc cản quang is go through what system? Why is it bright?
It's
okay. So when you see CT scan, anything that's so bright, that means it's real blood with the contrast in it.
Yes.
Okay. So this probably is a renal artery, right? Because it's really bright. So the contrast is in the renal artery.
Yeah. It's an artery.
Mm-hmm.
right artery.
Yeah.
Yes.
Okay.
Yeah.
All right. So good job. I like how you guys answer all the questions. That's good.
Yeah.
All right. So let's clear it, and then we move to the next one. Okay. All right. So see. So this is just basically you need to learn how to read a CT scan, because most likely they're going to ask you on the exam. So again, look at this liver is on the right side of the patient, spleen is on the left side, and then look at the little long thing. It's always a pancreas, and then you see the pancreas head is always next to the duodenum. So remember, that's why we talked about the gallstone last time. That the duodenum is really next to the pancreas. That's why when you have the cancer of the head of pancreas, it can actually press on the duodenum or the gallstone, the biliary system. So that's why we have to sort of pay attention. So this is the duodenum, and the larger thing is the colon, and then we have kidney, and there's probably the vena cava. Probably have need to know that. Okay, so we go to the GU system. So after the ureter, so the reason why we call it the GU, which is genital urinary system. So the genital basically is a reproductive, and then it combined with the urinary system, right? So that's why we call it the GU system. So it go from the kidney, it will pass through the the ureters, and from the ureters, we go to the bladder, which is thing, like this big thing over here, and it go to the urethra, and it go to the outside. But one important thing that, step one always want you to know is that the position of the ureters is sort of like, we call it water under the bridge. That means that the ureters is usually underneath the vas deferens in male, but it's also underneath the uterine artery in females. And why do they want you to know this? Because when people have some gynecologic procedures, either involve the vas deferens or the uterine vessels, they can cause damage to the ureters. So if on the test, if someone having some sort of a procedure, and all of a sudden they cannot pee, they cannot make any urine, then you should think about, oh, they might have either cut the ureters or they have damaged it. So that's why you have either obstruction or a leakage within the urinary system. Okay, so now we talk about the kidney stone. So the kidney stone, sometimes people call it the urolithiasis, or some people call it nephrolithiasis. So urolo and nephro are both the same name for the renal system. So the stone, basically, it can form any places in the urinary collecting system. So it can form in the renal calyxes, and then or the renal pelvis. It can go down to the ureters. It can get stuck in the bladders. It can get stuck in the urethra. So you name it, as long as it can pass through it, it can get stuck there. And it's really depend on the sex, age, and diet, and climate, and genetic makeup of the patient. So the size can vary. It can be very small. It can be very large. I've seen a very large stone before, and it's really painful. So they can occur mostly commonly in men, and also in the summer because of due to insufficient fluid intake. That's why sometimes people have a kidney stone. And like you guys say before, presentation is a colicky pain and flank. So the flank, which mean that it's on the sides, and it radiates to the groin. Okay, and I want you guys to explain to me how does a kidney stone cause pain? All right, so let's see, Mai, why do you think the kidney stone cause pain?
Hello.
Yeah.
So when the stone move, when the stone move, the stone will have the small injury with the urine tract. So that's one thing that causes the pain, and second one is the urine block. So the pressure pain.
Okay, so you think that the pain is caused because the stone is scratching the urethra or whatever the system and cause pressure is causing pain? Do you think so? Okay.
Yes, and the pressure pain also. Pressure.
Okay. So pressure on the structures cause pain. Okay. So why does it cause colicky pain then? If it's basically, so if you have a stone, it keeps scratching the area, then why don't you have constant pain? Why it's a colicky pain?
Yeah, I forgot that. Normally, they doesn't, when it doesn't move, the stone cannot move itself.
Yeah.
So the urine tract, like the ureter, have to like contract to push urine and then also push stone.
So you know when you have a stone in the ureter or the urethra, you know what is your ureter is doing, trying to get rid of the stone?
The ureter?
Yeah, whatever. Yeah. So let's say if you have a stone in the blood vessel, even in the blood vessel, anything that block the blood vessel, what does a blood vessel do to try to get rid of that area?
Will dilate.
Yeah, and constrict, right? So it's like a spasm. So
yes.
Yeah, so think of the stone like coronary disease. When you have like an atherosclerosis, or not atherosclerosis, like a blockage, your artery start to spasm. So that's why when people have chest pain, most of the time because of the spasm. Same thing with the stone in the urethra. Your urethra trying to get rid of the stone, so they spasm. So the spasm is what causing the pain. So sometimes if the stone gets stuck in the urethra, it sits there, but it doesn't spasm, then there's no pain. So it's only cause pain when it's spasm and trying to get rid of the stone. So that's why it have like sometimes it can cause colicky pain, or sometimes it can be really sharp pain is when they spasm. The urethra is spasm and trying to get rid of the stone. And sometimes that's why you have nausea and vomitings, and the patient sort of have to move to kind of relieve the pain. And one of the fear complication of the stone is that it causes a blockage. So any time that you have anything that block the system, anything that behind it can get infected, because the urine is a breeding ground for infections, for bacteria to grow. So if your urine is not moving, then you can cause infection. And the second thing is hydronephrosis. Basically mean that it just causes the urethra to become dilated. And when any structures become dilated, that means it's not functioning normally. So that's why you have to get rid of the stone to sort of help with the urine flow and to cause any damage to the system. So in diagnosis, so abdominal X-ray is helpful in some cases, but not all cases, because not all the stone can be seen on the X-ray. And also non-contrast CT is probably one of the best technique to help us see the stone. And then we have ultrasounds. And sometimes when you see someone come in with blood in the urine, first thing you order is the UA, which is a urine analysis, to make to see that those actually. Okay, so let me ask you, why do we do urine analysis when you see like a bred urine? Like let's see Joe. So why do people do urine analysis when they see blood in the urine?
Well, because when they do the urine analysis, they can find something else. For example, white blood cell.
Okay.
Or nitric.
Yeah.
It's the factors make we think about infection, urine infection.
So what other things that can make the blood? Make the urine look like blood?
Yes. For example, the inflammation or infection.
No, I'm asking more like what causes your urine to become red?
That means injured of the urine tract.
I get it. Okay, I understand. So, but then what exactly make the urine become red? What is the so what makes the blood red? Why is our blood red?
The hemoglobin.
Okay, right. So in the same thing in the urine, the hemoglobin makes it red. But what other thing can also make it red? Let's say if someone come in with like a muscle damage, would that person have red urine?
Yeah. Hey,
what's the other globins? There are two globins.
Yes. Sorry.
Yeah.
At moment I forgot that
Yeah.
one, but I know
So
what you mean. Yeah.
yeah, so myoglobins and hemoglobins. So that's why sometimes when people have you know, muscle damage or you know, rhabdomyolysis, the urine can also be red too, but it's more like myoglobin. There's no hemoglobin in that. Okay. Oh,
Yeah.
that's great. Okay, so
Thank you.
now we're going to move on to see the imagings. Okay, so now we have to sort of pick out why do we choose one imaging versus the other when we talk about, like, if you have a patient come in and you suspect that they have a kidney stones, depends on, you know, what you have at hand, you can actually use it. So KUB, which is kidney, urine, and bladder plain film, which basically just it's an X-ray. So it allows you to evaluate the urinary tract stones, but not all the stone can be seen on the X-ray. So when someone say that the it's radio opaque, mean that, you know, radio opaque mean that you cannot see it through, so it's not transparent. So basically, it's appear a little bit wider on the X-ray. So when you see opacity, why do we see you know, basically why is the bones white on the X-ray, right? It's basically due to the calcium. So same thing with the stone. So the reason why we can see the stone on the X-ray is if it have calcium in it, then it become white. So if you can see right here, you see little stone right here, it's white because it have calcium in it. So, but not all stones are you know, contain calcium. So that's why some of the stone are not seen on the you know, KUB or the X-ray. So that's why it's not sensitive enough. So, you know, it can be seen incidental, but not like a screening test that people use to sort of diagnose the stone. So you can see stone on the UV plain film, but it's not sensitive. It's very poor sensitive. All right, so the next, let's see. So the next imaging technique that we use is the CT scan, which is very common. And now most people will use a non-contrast abdominal CT. So I want someone to tell me, when would you use, why non-contrast? So let's go for Zhao.
Yes.
Yeah, why do we use non-contrast on the abdominal CT? So tell me exactly, what is abdominal CT? Like, what is a CT?
They just would like to know the structure of the system.
Yeah. Okay, so when would you use contrast in abdominal CT?
Maybe when they would like to observe the whole system from the kidney until when the urine go out to the bladder.
Okay. Yeah. Yeah, you know, you're right. And maybe if you have an infection, then, you know, you see the contrast will enhance also. Okay, so so the advantage of, you know, having a non-contrast abdominal CT, that it have a greater sensitivity. That means that it see. So when you see something is greater sensitivity, mean that you can see more, you know, stone with it. So it's non-contrast CT probably the best test because it's the most sensitive and also most specific for stone. So on the exam, if you know, they tell you to pick between different imaging techniques, then you should pick a CT. Non-contrast CT, and it's relatively safe because there's no contrast to use with it, so there's no allergic reaction, there's no toxicity, and it's most likely detect all stone regardless of the compositions. And you can also evaluate other pathology, you know, like appendicitis or ovarian cyst, because when people come in with abdominal pain, you know, if it's a right lower quadrant pain, then you think about appendicitis, but sometimes it could be a stone stuck somewhere along the urethra, and it could be ovarian cyst also. So that's why it's also good to you know, exclude other differential diagnosis. The only negative thing about it is that it's a little bit more expensive than KUB, and ultrasound is a little more time consuming than the other techniques. Okay. So now, so since, you know, non-contrast CT is so great, why do you think that we use ultrasound? All right, so why do you think we use ultrasound? Sometimes we use ultrasound instead of non-contrast CT.
Hello?
Yep. When would you use ultrasounds?
If I have a CT, I would not perform ultrasound.
No, I'm saying like in this case, I will use ultrasound, but in which case? I cannot use non-con CT. This is how the test gonna test you. Okay, so all those tests above can detect a CT. I mean, it can detect a stone, but in which case do I use ultrasound? Think about condition that you cannot use cannot use CT or X-ray. When will you use that?
Yes, pregnant woman.
Exactly.
And the patient that have
you can speak in Vietnamese. If you cannot find the word, speak the Vietnamese, and then I try to like translate it into English. So khi nào bạn không xài ultrasound, không có xài CT scan. So pregnant is one, right? What's the other one? Have you seen anyone that get a CT scan? It's a big machine.
A patient got no, it's the MRI.
Yeah.
Sorry.
It's okay. No, sometimes people are very claustrophobic, mean that they cannot be in a contained space. Those people, they don't like to get a CT scan, so you can go on ultrasounds on them. But on the test, most likely they will test you is at the pregnant woman, basically. If they're pregnant, you cannot do CT scan and X-ray. And why is that?
Because they're likely that their X-ray will cause their DNA.
Okay. So so the radiation, right, from this X-ray and the CT scan. So CT scan basically is an X-ray, but it's like a multiple direction, and they computed tomography. So they combine, like 360-degree to form this the structures. But it still uses the same radiation, energy. So that's why it's very toxic. So that's why you cannot use in a pregnant woman. So this is how they're going to test you. If they ask you to pick for an exam that is the most useful, then you have to use the non-con CT, okay? And then if there's a pregnant woman, then you use ultrasound, okay? Don't pick KUB because that is the most, like the poorest out of them all. So most likely it's not going to be the right answer. So again, prefer for people with pregnant women, and also some people with allergic to the IV contrast. It's not dependent on the composition of the stone because usually you only see you use shadow behind the stone to predict where the stone in the kidney. So that's why it really doesn't matter what the stone is made of. As long as they have a stone and they have a shadow behind it, you can see it. And you usually see, again, so distal acoustic shadowing. That's what they use to sort of detect it. And also the other advantage is that it can also detect hydronephrosis. Again, you can see the dilations of the renal system, and it's pretty good sensitivity, and it's very easy to use. Okay, so this is the this is right here. Okay, so we can see the stone right here, and there's a shadow behind it, right? Okay. All right, so next we're gonna go to the type of the kidney stone. So this is probably where all the test, step one will ask you, what type of stones are they? In clinicals, we don't care that much, but in step one, it's absolutely, they will ask you. So the way that I approach, the kidney stones, I think about different, put it into a different bucket, okay? So the first thing that I put them in is a pH. So the stone that can have when, your urine pH is low, when I think about acid, right? So uric acid, the low pH, and 16s. So the way that we remember 16 is that, 6 is basically 6 sides. So that's why it has the shape is hexagonal. And also when you say 16 is, when you say acid, 16 it sounds very similar. So that's why I think of them as having low pH, all right? So think about the pH first. So low pH, then you think about uric acid and 16. And then you have high pH, then you have calcium, so contain calcium oxalate, calcium phosphate, and ammonium magnesium phosphate. So those are the two ways that to remember it. So the first way is the pH. Second way is the shape of the kidney stone. So these, there's no way that you have, there's no trick for it. You have to remember it. So calcium oxalate. So when I think of oxalate, I think of octahedron. So let me just prove it. So O, remember O. So octa, what does octa mean? Octas mean 8, right? So it's usually an 8 size, and they usually have an X in the middle. So you look at the pictures, this is an X, and you think you have 8 sides. So you think about calcium oxalate. So octahedron, calcium oxalate. And calcium phosphate, thinking about coffin, like a coffin, like a wedge-shaped prism. So sometimes they call it like a coffin lid. And the most important one is probably the staghorn. This is a staghorn. And the reason why we call it a staghorn is when you think of the deer, like con hươu, nó có cái càng phía trên á, so it looks like a staghorn, so that's why they call it staghorn. And this one is absolutely important. You have to know this one. You have to know what it looks like, because most of the time people get a huge staghorn, stone gets stuck in the urinary system. That's when they get, their kidney become failing, and they have UTI, severe UTI. So remember that staghorn, ammonium magnesium phosphate. And the staghorn is a huge, like a stone, like so big that you have to look at it. There's no microscopic, it's just huge. And then uric acid is a rhomboid shape. So rhomboid is like this. It's like four, like a sort of like a rectangle. And 16 is the same. Where when you think of 6, think about 6, which is 6 sides, so hexagonal. So which is E on that one. So that's how you remember the side. So either by the shape of the stone or by the pH of the stone. Okay. All right. So that's all I'm gonna ask you for the type of stone. And now we're gonna go a little bit about, so what kind of, we have to go deep into the stone, the type of stone. So the first one is the calcium oxalate, which is the most common, let's see. So this probably is the most common stone that you're gonna see in adults and endurance. So when you think of stone, first thing you think about is calcium oxalate, and it's usually radially opaque. So like I say, remember, opaque means that it's white. You cannot see through it, so that's why it's opaque. And again, it looks like octahedron, so oxalate, octahedron. So there's a lot of causes for the calcium oxalate to form, and the way you remember the formation of the stone is the combination of calcium and then oxalate. So basically, it's a balance between the calcium, oxalate, and citrate. So when you think about calcium, the way that we get rid of the calcium is that the calcium will bind to the oxalate in the gut to form calcium oxalate, and these are not absorbable, so that's why it's excreted through the GI tract. Okay, so the calcium has to bind to the oxalate and then excreted through the GI tract. So if you have a low calcium diet, then you have increased amount of free oxalate, and this oxalate then absorb into the blood. Okay, and then it go to the urine, and when it's in the urine, it will form a kidney stone. All right. So in the urine, if you have high level of oxalate, so that's why you have hyperoxalate, then you have increasing risk of forming the stones. So that's why sometimes they give people vitamin B6 because it decreases the amount of the body to make oxalate, and it helps to treat the kidney stones. All right. So another reason why they also have calcium oxalate is because hypercalciuria. So in the urine, so you see urea mean that in the urine. So hypercalciuria mean that high level of calcium in the urine. Hyperoxalate urea mean that high level of oxalate in the urine. So these two will combine together to make the stone. So you don't want any of these high level of calcium and high level of oxalate in the urine. Okay, so you have to think about high level of calcium in the blood and in the urine. Okay, so try to separate them, and also hypocitrate urea. So the function of the citrate is that you think about citrate is the opposite of the calcium. Okay, so usually citrate will bind with the calcium. So if you have high level of the citrate, then you have low level of calcium in the blood. But if you have hypocalciuria, mean that you have low level of citrate, then you have a lot of calcium in the blood, and more calcium in the blood, and more calcium in the urine. So that's why this one is the opposite. So you have hypocalciuria, then you have more chance of forming the calcium oxalate in the urine. Okay, right. So I know it's very complicated, but once you sort of make it out, like understanding the pathophysics of it, it try to make it a little bit easier for you. All right, so the next one is the calcium phosphate. So this one is a little bit easier. So you think about phosphate and calcium. So in the urine, you need high level of the phosphate, okay? High level of phosphate and calcium in the urine, they will combine and they will form the stone. So what condition called high level of phosphate, right? You think about cancer, right? Bone cancer can cause the bone to break down. So they release the phosphate in the blood, and your kidney will try to get rid of the phosphate. Same thing with PTH. Same thing with high level of vitamin D3. Those are the conditions that causes the high level of phosphate. So this one, you try to treat the underlying disorders, whatever the disease that causes the phosphate to be increased in the urine. Then when you treat that, then the stone will stop forming. Okay, so you treat the underlying disease, and we can talk about the low sodium diet a little bit later. So can anyone explain to me why low sodium diet would help with a calcium stone? Why would you want someone to have low sodium diet? Anyone? Give it a try. All right, so Lê Phương Thảo, you want to give it a try? How does low sodium diet will help?
Sorry, you...
Okay, so the stones, right? The calcium stones. How does lower the amount of sodium that you eat will help with the calcium? So tell me, in the kidney, right? How does the kidney reabsorb sodium or calcium? All right. This is really hard. So I'm gonna. Okay, so Yong. Okay, Yong. Yeah. So go ahead.
Yes.
Give it a try.
And we kidney absorb sodium is usually in the thick ascending, and
okay.
It absorb calcium.
Okay.
Yes. When we reduce sodium in diet, it will retain calcium. Yeah.
Okay. So you say that when we eat low sodium, your body will try to retain more calcium?
Yes.
How does so? What's the connection between sodium and calcium?
It's calcium. It's potential of
So okay, speak in Vietnamese. Explain it to me in Vietnamese.
Những cái kênh mà ở ống thận, ở ống thận, ở quai hấp lên. Hay mà dày cái kênh giữa kênh là natri so với clorua á, nó khi mà nó hấp thu thì nó kéo thêm cái calcium mà nó đi vô thêm.
Okay, see, I understand what you're saying. Okay, so in the renal tubule, when you try to reabsorb sodium, you also reabsorb calcium at the same time. Is that what you're saying? Okay, so exactly. So that's how it works. So when you have low sodium diet, right? So your body will try to retain the sodium. So at the same time, it will retain the calcium. So that's why if you retain more calcium, that means you have less calcium in the urine, right? So less calcium means it's good, because less calcium means that less formation of the stone in the urine. Okay, I hope everyone understand that part, because it's pretty important, because we do tell the patient to lower down the amount of sodium when they eat. Okay, yeah, thank you, Yong. That was really nice, the way you explained it. Okay, all right, here. All right, so I'm gonna test you guys that later, because I feel like not a lot of people understand that, but this is basically how it works. Okay, so calcium is passively fall reabsorption of sodium and water. So if you increase the diet, the sodium intake, then you reduce the sodium reabsorption, and that's why more calcium is excreted in urine, then you have hypercalciuria. Okay. Okay, so that's why you want the patient to have low sodium diet. All right, Yong, you have a question?
No.
Okay, all right. So you raise your hand, so you can lower it.
Check and we'll stop it.
Okay, yeah. Sure. All right, so next one. So we're gonna talk about the struvite. So the ammonium magnesium phosphate stone, we can also call it a struvite stone. So you need to know this one because it's tested so common. That's why it's also the second most common. It's the second most common stone. The reason why it's highly tested is because it's associated with UTI, which means infection of the urease positive bacteria. Okay, so you need to know these three bacteria. So the Staphylococcus saprophyticus, Klebsiella, and Proteus. There's another. So this one P is stand for Proteus. Proteus. Okay, so you need to know these three bacteria that cause the UTI. So these stone, you see this large stone over here, is so big, you cannot miss it. So if you have a CT scan and it show you a big white thing in the middle, that's definitely a struvite stone. Just remember that. And this is definitely opaque. Remember opaque? Opaque means that it's white. You can see it, right? So this is white, okay? So big stone caused by UTI. Remember, urease positive bacteria. And how do you treat it? You give them bacteria, but at the same time, you have to remove it to prevent any further UTI. All right, and let's see, someone has, okay. All right, so remember that, big stone, struvite, ammonium magnesium phosphate, UTI, that's what you need to remember for that stone. Right, so next one, we're gonna talk about uric acid. Okay, so anyone tell me uric acid, what other condition that you remember uric acid from? All right, I'm gonna pick Thanh Bùi.
Yeah,
yeah,
we learned it in the gout.
Gout. Okay, gout. Great. All right. So now tell me, how does what other condition that have higher uric acid besides gout?
Tumor necrosis syndromes.
Yeah, we say right here, any high cell turnover, so hyperuricemia, high cell turnover, like tumor lysis syndrome. And when do you see tumor lysis syndrome? When someone receiving chemo treatment for cancer, right? So leukemia, myeloproliferative disease, or someone who have cancer and now receiving treatment, chemotherapy, then you have high cell turnover. And what does it mean, radiolucent? Lucent means that if you can see through it, so see through, okay? So that means that you will not see it on the X-ray. So that's why it's radiolucent. So that's why you won't be able to see it if you do a KUB. So this one have the rhombus shape, remember? Rhombus shape, and also uric acid. So you remember low pH, okay? Low pH, that's acid. So that's why you alkalize the urine, right? Because of acid in the urine, so you alkalize it and you solve the problem, right? And allopurinol, what does it do? It lower down the uric acid. So that's why just stop formation of the stone. And also you limit the purines in the diet. Why? Because purines is needed to form uric, right? So that's why. Okay, so remember acid, low pH. All right, next one. So both calcium and uric acid, because and let's see. Sometimes you see that the uric acid concentration can promote the formation of both calcium and uric acid stone, because the uric acid can also sort of precipitate and act as like a breeding ground for calcium deposition. So that's why sometimes you can have both calcium and also uric at the same time. Cysteine is the most least common. And what do you need to know about the cysteine? What you need to know is that it's actually happen in young kids. So when you see a young patient, then you think about cysteine. These are usually familial problems. So that's why they have genetic problem, genetic defect in the proximal column of the tubules. So this because of the reabsorption of cysteines. So cysteine in the urine, they will combine together and they form crystal. And how many size the cysteines crystal have? Remember 6 hexo, which means it's 6 size. Same thing because it's 6, like acid. So I think about low pH, right? Low pH. So one of the treatment for it is to alkali the urine, right? Low protein diet, same thing, protein breakdown to, form cysteine. So that's why low sodium diet, again, we talk about the reabsorption of calcium and increase in fluid intake. All right, so keep this. All right. So remember, recurrent nephrolithiasis, recurrent kidney stone in a young patient, then you think about cystinuria. Okay, so that's why you have to do the test. I think remember the test is a nitroprusside test. I will talk about it later. So remember this hereditary. So that means it's genetic problem. So that's why it happened in young patients. So the transport defect also cause poor reabsorption of ornithine, lysine, and arginine. So these are all amino acids. So to remember that, we call it COLA. So C stands for cysteine, O or ornithine, L is for lysine, and R for arginine. And the cysteine is poorly soluble. That's why it forms in the urine. Okay, so usually benign in childhood, right? So how do you diagnose this? You use a sodium cyanide nitroprusside test. So this is the only test that can take to test this cysteine. If you see this test, think about the cysteine stone. Basically, it's a qualitative screening test. It's to basically detect the presence of cysteine in the urea. So a positive test is when you see a red-purple in the urine. So first they use cyanide to convert cysteine into cysteine. So you see this is different. This is 16. Oh. Okay, so this is 16 and this is cysteine. So there's two, there's an actual I in there. That means that is sort of like cysteine, then it add nitroprusside. Then this will react with the nitroprusside to become red and purple. Okay, so they don't detect the the cysteine, they detect the cysteine. They're probably not going to test you that, but just remember that young patient, absolutely young patient with the kidney stone, then you think about cystinuria or the cysteine stone. Okay, all right, clear. All right, and how do you manage the kidney stone? So like I said before, in clinical, practice, when you see someone have a stone, then you ask yourself, if that stone gets stuck somewhere, is that stone big enough to need to be require surgery to retrieve it, right? Because a lot of the stone, they just pass by itself. So how do we detect the stone? Again, you do ultrasound if the patient is a pregnant woman or they cannot be in a CT scan. They have, allergic reaction to IV contrast, and then you use non-con CT, which is the best test for detecting the stone. Do not use KUB because most likely it's very poor sensitivity. So how do you treat it? First, the patient is really in pain. Then you give them narcotic, you give them NSAID to help with the pain. So then you look at the size of the stones, right? So if the stones is less than 5 millimeter, most likely it will pass spontaneously. So all you need to do is manage the pain and give them, tell them to drink more water to sort of help to pass the stone and to lower down the chance of forming further stones. Sometimes you can give them some medication to help with the, to help push the stone. So basically you give them the alpha receptors are found on the distal ureter, the bladder neck, and the urethra. So you do alpha blockers to help to relax the ureters and the urethra so that, when it's relaxed, the stone can pass through it. And if you have recurrent stones, then you need to collect the urine. If the first time you have the stone, you don't need to do the collect the urine, but to keep the patient having stone over and over again, then you have to collect the stone to sort of find out what kind of stone it is, you know. So you measure the calcium, citrate, uric acid, oxalate pH, and the sodium level. And if the stone is larger than 10 millimeter, or it gets stuck somewhere, and you know, it's big enough to obstruct and it causes hydronephrosis, it's caused your kidney to fail, then you have to call urology because they need to take out the stone. All right, so in order to test, you know, people again, this is what they're going to test you, how to prevent kidney stone from forming, right? All right, so I'm going to ask some people, tell me, first, do you increase or decrease fluid intake? All right, I'm going to ask Tân Bùi. You think that patient, you want patient to drink more fluid or less fluid?
More fluid.
Okay, what about sodium? You want people to take more sodium or less sodium?
Less sodium.
Okay, tell me why less sodium?
Because calcium follow the reabsorption of sodium, so
okay.
It decreases.
So you want patients to take less sodium, okay?
Yeah.
So, and then, you know, your body trying to counteract, right? So they trying to reabsorb more sodium. I mean, they reabsorb more calcium in the blood. And what does that do to the calcium in the urine? It's called less calcium in the urine, right?
Yeah.
Yeah, so that's why you have less chance to form the calcium stone in the urine, okay? All right, I'm gonna pick somebody else. Let's see, Mai. How about protein intake? Do you want more protein intake or less protein intake?
Less protein intake.
Okay, and tell me why.
Okay, so the more protein intake, the more product of the protein metabolism will secrete to the blood, and then will increase.
All right, I like that. Okay. All right, how about calcium intake? Do you want patient to take more, less, or normal? All right, let's go. All right, let's see. Lê Phương Thảo, do you want more calcium intake, less calcium intake, or normal calcium intake? Hello, Phương Thảo. Okay, okay. Okay, Phương Thảo, go ahead. You want more calcium, less calcium, or normal calcium intake? And tell me why.
I think less calcium intake.
Okay. Normally, you know, people would think like you want less calcium because you don't want, you know, so less calcium in the blood means that less calcium in the urine, right? Yeah.
No.
So you have high calcium in your blood. That means your body will try to get rid of the calcium in the urine, right? So you have less calcium in the blood, then your body will secrete less calcium in the urine, right? Does that make sense?
Yes, I think so.
Okay, all right. Usually that would be the case, but in this case, it's actually the opposite. Okay, so I'm gonna have someone. So someone just raise hand, and I want that person to. Okay, Đại học Y Dược. Okay, so I don't know what's your name.
Yeah. I'm sorry, I used my university account.
Okay, no problem. All right, tell me. Okay, tell me. You want more? You want your patient to take more calcium, less calcium, or normal calcium intake?
I think normal.
Okay, why? Why not less? Because it makes sense, right? You don't want you want less calcium in the urine. So why are you telling your patient to take normal calcium?
Because if you take less amount of calcium, it will decrease the calcium in the gut.
Okay.
And, so that the oxalate will increase will absorb in the gut and increase in the blood and secreted by the kidney, so it increase the chance of formation of kidney stone.
Okay. Did you read my thing or you think of it by yourself?
Yeah, I think by myself.
Okay, that's great. Yeah. So that's how you should think on step 1. Okay, so these are the high U point. Okay, so you absolutely want a normal calcium intake. Like you say, it's normal to think that you want low calcium in the urine, then you want your patient to take less calcium, right? But that's the opposite. You're exactly right. The way you explain it is nice. So again, remember the calcium and oxalate will bind together in the GI tract, and it become unabsorbable. And but if you take less calcium in the gut, then you have more free oxalate, in the gut, and then in the gut it reabsorbs the oxalate. So remember, more oxalate in the gut than more oxalate in the urine, and you don't want more oxalate in the urine because that will increasing the chance of forming the calcium oxalate in the urine. Okay, that's really nice. All right, how about citrate? Do you want more or less citrate? You can answer the same question.
Yeah, I think low citrate. Yeah, low citrate, right?
I will let you think. You want low citrate or you want high citrate?
Yeah, let me a minute to think.
Okay, all right. So you want less. So remember so you want hypocitrate urea, right?
Yeah.
You want hypocitrate urea or you want hypercitrate urea? Remember, in the urine you don't want high level of calcium. You want high level of oxalate, right? But you don't want low level of citrate.
Yes, citrate. So
okay.
Increase.
Yeah, increase. Exactly. All right, same thing, oxalate in diet. So you want lower the oxalate in diet, right? Okay.
Yeah.
Yeah. All right, so increase citrate. See, so just try to think, walk it out a little bit because it's really confusing to think, right? So just think about what in the urine. So you want low level of, calcium, low level of oxalate, but you want high level of citrate in the urine. So that's why you have to increase the citrate level, okay? All right, so and then sometimes you use drug therapy. So again, remember for the uric acid, you lower it by using allopurinol, right? And then for the stone, the low pH stone, then you alkalize the urine by using urine alkalization. And one of the side effects of thiazide is, hypoglycemia. So it causes hyperglycemia, it causes hyperlipid, hyperuricemia, and or hypercalcemia. But that's you want that side effect, right? You want your blood to have more calcium, so less calcium in the urine. So that's why sometimes people use thiazide diuretics to help with that. All right, so the complication, like a lot of people tell me before, the complication of the kidney stone is what? When it gets stuck in the kidneys, it can cause obstructions. So anytime you have an obstruction, it can cause the kidney to fail, okay? Your kidney is not gonna function normally. So that's why, right? And then anytime you have a blockage in the system, like, in your ureters or your renal pelvis, anything behind it can cause UTI, which is infections, and infection can lead to sepsis. Again, surgery is a treatment. So you don't want the stone to form and obstruct the urinary system. When it gets too large, you need to do surgery to get rid of it, and surgery always comes with a side effect. All right. So I think that is a lot, for today. So we're gonna have basically the objective. So you need to know the location of the kidneys, especially on the CT scan. Okay. So sometimes they will show you pictures of an X-ray or a CT scan. You need to know where the kidneys are, and you have to know from the renal blood flow. Remember the afferent and efferent. Okay. So afferent is arriving to the glomerulus, and efferent means that exiting the glomerulus, and know the structures that pass on top of the ureters. So if your ureters would pass under the uterine artery in female and the vas deferens in male before reaching to the bladder. So that's the thing you need to remember. And that's the second thing, you have to understand the different type of kidney stones. Like I say, you separate the kidney stone by shape and by pH. So low pH, uric acid, cysteine, okay? And then the other are three: calcium oxalate, calcium phosphate, and then ammonium magnesium phosphate. Those are high pH. Sorry. And then you divide it by the shape. So remember oxalate, you know, octa, I mean 8, so it have 8 sides, and it have an X in the middle. And then calcium phosphate is just a coffin lid. And then think about the ammonium magnesium phosphate is a big words, right? Think about big stone. So you think about struvite stone. A stone look like a staghorn, you know, on a deer. So that's why it's obstructed the urinary system. So big stone, think about the ammonium magnesium phosphate. And then, you know, you think about uric acid. And then, you know, the last one is a 16. So 16, think about 6. 6 means that 6 sides, okay? And then you need to know radiolucent versus radio opaque. So anything that have low pH, I think of radiolucent. So you won't see it like uric acid, you won't see it. Anything with calcium, then you radio opaque in that, you know, with calcium, it bright up on the CT scan, it bright up on the X-ray. So calcium oxalate, calcium phosphate, and you know, anything with calcium, then you see it. And then common disease associated with each type of stones. Okay, so remember the most common, you know, kidney stone is calcium stone, so calcium oxalate. Remember calcium phosphate. Any disease that call elevated phosphate level, you know, high level of PTH, people with cancer, then would cause us the calcium phosphate. Okay, and then you think of uric acid stone, people with gout, right? People with high, you know, cell turnover, like people that have cancer, and they receive treatments, so their cells are lysis. So to remember uric acid for that one. And you see a young patient with recurrent UTI, then you think about cystine stone. Okay, and if you see a patient with UTI and then have urase positive, you know, bacteria, then you think, and it's a big stone on the imaging, then you think about the ammonium magnesium phosphate or the struvite stones. And then remember the imagings. Okay, so X-ray not very good. Okay, ultrasound very good for pregnant women. Non-contrast CT the best one. You see it, pick it. And then also preventions. So you have to understand why you have to tell the patient to eat less sodium. Okay, but eat more citrate food, you know, or vegetable. Okay, and also drink more fluid. Right. So to think about the dietary. What do you tell your patient to eat less, more when it comes to kidney stone? And complications of the kidney stone, you know, obstruction, UTI, and surgery. All right. So, anyone have any questions so far before we go to the questions? All right. No questions. All right. So we're gonna do the question. Okay. 1 second. Let me share the. Okay. All right, so these going to be the objective. Just remember to review it when you go through it. Same thing for the, you know, the size depending on the stones. How do you manage it? Okay, so less than 5 millimeters passes spontaneously. Less, you know, less than 10 millimeter, then you think about medical management. More than 10 millimeter, then you need to call surgery to get rid of the stone because it's too big to get passed through the urinary system. Again, you know, pain control, hydration, give them a lot of fluid, alpha blockers. If, you know, they cannot pass a stone by themselves, then you give them alpha blockers. And if they repeatedly keep having a stone, then you have to collect the urine and, you know, make some sort of test to find out what kind of stone is it. All right, so question number 1. So you have a 22 years old woman present to the clinics with symptoms of left-sided back pain with blood visible at the end of the urine stream. And you do a UA and it show the pH of 7.9 and specific gravity of 1.1. And they also result a positive for nitrite and also white blood cell S rate, but negative for ketones and glucose. Microscopic examination of the urine shows many red blood cell and many bacteria. Culture of the urine produces swarming colonies on agar plate. Which of the most following is the underlying cause of the patient's symptoms? So what kind of stones cause this patient? All right, anyone want to volunteer? All right, Tan Bùi, go ahead.
I think the answer is A, because I see the
so how do you approach this question? Okay,
I see the high pH level.
Great. Okay, so
I can see so many RBC here.
Okay, so when you see a high pH level, what are the two stones that you can eliminate from the answer choice?
I will eliminate the uric acids and cysteine.
Good. All right, so now you come down to three choices, okay? So what makes you choose A instead of B or C?
Because I see so many RBC and many bacteria here.
So any stone that gets stuck in the system, you can have red blood cell and you can have bacteria grow behind them.
Well.
Okay. So they give you a culture, right? The urine. And it shows swarming colonies on an agar plate. So, I mean, you are right, because most likely anything with a UTI and you see a lot of bacteria, most likely you would think about struvite stone, right? But like I say, these can cause infection, but the key one here is the swarming colonies on agar plates. What bacteria do you think they're talking about? Okay. No. Okay. So, all right. So you guys gotta study a little bit more bacteria, microbacteria. Okay. So Proteus is the characteristic is swarming colonies on the agar plates because they can swim. Swarming, they swimming. Okay. So protease. Remember, protease is one of the bacteria. What do you call those bacteria?
Proteus vulgaris.
Yeah, no, but what do you call that group? There's a group of bacteria. So this is a urease, right? Positive, right?
Yeah.
Okay, so when you think of urease positive, you think about ammonium magnesium phosphate stone, okay? Yeah, great job. That's exactly the answer, okay? So when you see some sort of UTI, then think of, the struvite stone. Okay, these two can cause stone too, but most likely it will not cause so many bacteria behind it. Or, any one of these can cause red blood cell because it can cause hematuria. Okay, any stone can cause damage to the uric lining, so you can have red blood cell. Okay, all right. But the key here is actually what type of bacteria they talk about. Okay, yeah, right, yeah. So that was great. All right. So we go to so again, you need to remember recurrent UTI, urease positive bacteria, think about AMP, okay? All right, remember right here. So I'm gonna circle it. So remember the infection by urate positive bugs. You have to remember this three, protease, Saprophyticus, and Klebsiella, all right? Those are the three key ones. All right, so the next one, question number 2, so the kidneys of a 65 years old patient with long-standing diabetes are examined at autopsy. One kidney is shown in the image. In the later stage of the disease, this patient frequently requires a Foley catheter to adequately drain his bladder. So what condition are most likely cause the anomalous appearance of kidneys? Is it acute pyelonephritis, ascending cholangitis, chronic pyelonephritis, hypertension, drug-induced interstitial nephritis? All right, I'm gonna pick somebody to tell me what does the pictures. Okay, so V, tell me what does a picture show you? All right, so I'm gonna circle this. All right, I'm gonna help you. What are these? We've been talking about the whole year, whole day.
The stone.
Okay, what is this?
It's a very big stone that's stuck.
Exactly. Yeah. Okay, so it's a big stone, right? All right, so this is the right kidney, right? Yes. So this is one kidney. This is one kidney. Tell me how do you compare them? Tell me how they're different.
The left kidney is bigger than the right.
Exactly, it's bigger, right? And tell me, what is this? What is this I'm circling right here?
It's a lobule.
Yeah, so a calyx is right. A lobe, calyx is, yeah, and this is what are the structures I'm circling here? Everything dumped into it. So we call it the renal pelvis. Okay.
Yeah,
all right. So when you compare this to this, what does it tell you? It's bigger, right? So this one is bigger than this one. Okay. All right. So you think this patient have a stone and it caused an obstruction, right? So that's why the urethra is a lot bigger. Okay. So what is the problem that you think? Is it acute?
No, I think it's chronic.
Yeah, so you think it's a chronic, right? Something is chronic, then it causes, to become a lot bigger. Acute is too fast to cause any of the dilation to occur. Okay?
Yeah.
So see, the question is not that hard. What about B? What is ascending cholangitis? I think we talked about it last class. What is cholangitis? What is chola?
I didn't attend the lab.
Okay. All right.
Class.
I would ask somebody else to attend the class. All right. All right, I'm going to test you.
Hello?
Yep. Tell me, what is cholangitis mean?
It's common by dog.
Okay.
No?
Yeah, I mean, in a sense. Okay, so what is chola? What is chola?
Chola is cholesterol, like.
I mean, you're right. So it is a cholesterol. So chola means bile, basically.
Yeah.
Yeah. So basically, cholangitis, ascending cholangitis, means that you have a gallstone, right? Gets stuck in the common bile duct, and it causes infections. Infection. So ascending means infection that ascending from the common bile duct. So you have a stone, and it's causing infection that's spreading upward. Okay. So that's what it means. So when someone tells you ascending cholangitis, then you think there's a stone somewhere that gets stuck in the common bile duct. All right. Okay. All right. So can it be caused by hypertension?
Still me or?
Yeah, it's still you. Yeah.
Okay.
Can it cause by hypertension? Can hypertension causes dilation?
No.
Okay.
No,
what does hypertension cause dilation of what? What structures hypertension affect?
Blood vessel.
Okay. I'm talking about the renal system now.
Hypertension will.
So so blood vessel, right? Blood vessel, and it go to what?
Like artery will go inside their kidney by their.
What is a functional unit of the kidney? So you have the afferent vessel.
Okay. Yeah, renin, angiotensin.
Okay.
So hypertension will.
Okay, so think about the structures I talked to you before, right? So the blood flow, right? It go from afferent vessel, it go to a structures, and it acid in the structures. So we call this efferent vessel. What is the structures right here? What is the structure that I'm drawing?
Like arcuate.
No.
No.
No. So remember, what is the functional structures of a heart, right? You have myocyte, right? Functional unit of a liver, you have hepatocyte. So functional unit of a kidney, what do you call that? It starts with a G.
Nephron?
Yeah, nephron or glomerulus, right? Okay, a glomerulus. So when you have hypertension, that's what it's affecting, the glomerulus. It doesn't affect this, okay? All right, so I want somebody else to tell me what is drug-induced interstitial nephritis. All right, let's pick Đại học Y Dược. You gotta give us a name.
Yeah. I want you to repeat the question, please.
Okay, so can you tell me what symptoms or what would you expect to see when someone have a drug-induced interstitial nephritis, which is E? Can you see E? Answer choice E.
No, I can't see the choice.
Okay, you cannot see any choice?
No, I just see A, B, C, D, but not D, E.
Oh, okay. So Okay,
It's
so
on my screen. Yeah.
all right, let me type it into the chat. All right, so can you? Okay, so let me write. So acute. How come I cannot chat? Okay, let's go back. So you cannot see it at all?
Yeah, I think all of
okay. All right, let's just scratch that one, okay? But the question is correct. So chronic pyelonephritis. So remember, it had to be chronic in order for the renal structures to become changed. Right. So we go to the next one. All right. So number 3. All right. So now you're gonna answer this question, okay? All right. So yeah. 30-year-old woman presents to the ED with colicky abdominal pain radiated to her groin area. Which organism is the most common pathogen associated with her underlying disease? Okay. Tell me what you see in the X-ray.
I see Staghorn kidney stone.
Beautiful. Right. I like how you call it a Staghorn right away. You're absolutely correct. Okay. And now what organism associated with this one?
Yeah, I think it is C, right? Proteus.
Yep. Okay, C. Great. Yeah. What's the other 2? We have 3 organisms.
Yeah, Staphylococcus saprophyticus.
Okay, saprophyticus. Great. Saprophyticus. Okay, one more.
And
you have to remember this. Because they will test you. Let's start with a K.
Klebsiella.
Exactly, Klebsiella. Okay, and when do you see Saprophyticus? What patient population you see Saprophyticus?
Pregnancy patient.
No.
Patient have surgery of the abdomen, right?
No. So UTI in young females.
Yeah, young female.
Yeah. So UTI in young female. Just remember that Saprophyticus in UTI in young females. Okay. All right. And when do you see Enterococcus faecalis?
Yeah, it's the Streptococcus group D that I.
Yeah. So so UTI, but what kind of UTI? So remember, Saprophyticus is UTI in young female. Enterococcus is UTI in. So have you seen anyone in Vietnam have VRE? Remember VRE?
Yeah, vancomycin resistant.
Enterococcus, right?
Yeah, Enterococcus.
Yeah. So that's the reason why they call it vancomycin resistant, because it's a very resistant bacteria. So that's why you see UTI in resistant drugs. Okay, so remember Enterococcus, remember VRE. Enterococcus, so E. coli. So where do you see UTI in with E. coli?
Yeah, I think it's the most common pathogens, but not cause the juvenile kidney stone.
It's not, but what populations? So all these can cause UTI, okay? So that's why they put this here. So this UTI, C is UTI that causes struvite stone, right? So this one you go to a struvite stone, right? So Enterococcus faecalis means that UTI that associated with VRE, right? And E. coli, then UTI in what patient population that you see it? All right. Anyone else? You have to know this. So E. coli, who get E. coli? UTI. All right, I'm gonna have to ask you now.
I guess pregnant woman?
No. No, yeah, but you know, like this is not the most common. All right, I'm gonna ask Tan Bùi. Who do you see E. coli? No? Okay, let's see Yung. No one knows? Really? E. coli, old people? You don't see people with E. coli? Okay, so remember, E. coli is old folks, like old people, the UTI in old people, okay? Just remember that. What about Pseudomonas? Pseudomonas. Who do you see people with Pseudomonas?
Yeah, in patient with immunocompromised patient.
Okay, so that's one, but what's the other common one that you always scare of?
Chronic disease. chronic disease, diabetes.
Diabetes, right?
Yes.
Diabetes. When you see someone with diabetes, your antenna should go up like Pseudomonas, right? That's why you're scared of that. Okay, so for step 1, you have to know the association. Okay, so most common. So you have the thing in your head. Pseudomonas mean diabetes, immunocompromised. E. coli, old people. Okay, Staphylococcus, young females. And then you think about Proteus, mean that's is a struvite stone. What about Serratia? What color do you see Serratia in? Anyone have shower in your room and you see you know, like the red rust? You know what I'm talking about? Like when you go to the bathroom, when you go to your bathroom, right? When you go into your shower and you see like the red marks all over the place, that's actually Serratia. So that's why it's red. So how I remember is the Serratia is mean red. Yeah. So usually they found in, you know, like shower head or you know, in the bathroom basically. Okay, all right, so that's a lot, but you have to remember the association for the UTI. So all of this is talking about UTI, and you have to remember what bacteria call what kind of UTI, okay? So the test will ask you that. All right, so remember this one is a urate positive organism, so Proteus, Klebsiella, Staphylococcus, all right? All right, so remember this. Okay, so remember E. coli, you know, leading cause UTI. So you need to know this basically. So, so remember Serratia, like some strains that produce a red pigment. Remember Ser, which is red pigment. Okay, and Enterococcus is non-secomial and drug resistant. So remember VRE. Okay, Proteus. Remember the swarming that I talked about before. It's like a swimming bacteria. All right. And Pseudomonas is, you know, non-secomial drug resistant and usually in, you know, immunocompromised and diabetes. All right, so when you order a test and it come back at leukocyte esterate positive, what does that mean? You see it all the time, so you have to understand what it means. All right, so I'm gonna pick Yom. What does it mean when one patient have UTI, all right, so infections, and the test come back as leukocyte esterate positive? What does that mean?
Leukocyte. Sorry, I don't understand.
Okay, so a patient had UTI, right? Like nhiễm đường nước tiểu, right?
Yeah.
Yeah. So you order like the test, you know, like the you know, like leukocyte, nitrite, and urate, right? So the test is positive. What does that tell you? Like, what does that mean that it's the leukocyte esterate is positive? Okay, so
urylysate.
Yes. No, yeah. So leukocyte esterate. So if it's positive, what does it tell you? Right, you order the test, right? Patient have UTI, right? You order these tests and it come back positive. What does it mean? You can say you don't know. You say you have to learn how to say I don't know. You know, if you don't know, just say I don't know. No? Okay. All right. I'm gonna ask Tan Bùi. So if patient have UTI, you order the test, right? Leukocyte esterate is positive. What does that mean to you?
I think it's a sign of.
It is sign UTI.
Sign UTI. What does that mean? Okay, speak in Vietnamese then. Leukocyte esterate positive. Nghĩa là gì?
Có nghĩa là cái xét nghiệm nhiễm trùng tiểu nó tổng phân tích tiểu dương tính thì
dương tính.
để chẩn đoán xác định được cái nhiễm trùng tiểu.
No, no, that's not what I mean. So the test, right? Nó dương tính nhưng mà nó dương tính cho nó nói cho mình hiểu là cái gì, right? Trong cái urine nó có cái gì mà làm cho cái test nó positive.
Có nitric, có cái.
No, we're talking about leukocyte esterate only. If it's positive, what does that mean? All right.
Có leukocyte.
Okay, so what is leukocyte?
Yes.
What does leukocyte mean?
Neutrophil.
Yep. So it's white blood cell, right? That's all it means. It have a white blood cell in the urine, right? Your urine should not have white blood cell in it. The only time you had it is when you have infections. All right.
Yeah.
So that's why when you order a test, you have to understand, you know, like what exactly it means when you order it. Okay. So remember the Uric test. If it's positive, what does it tell you?
We'll have a urea. No, the bacteria produce urea.
Yeah. What are the 3 bacteria that we talk about?
E. coli, E. coli.
No, not E. coli.
Proteus.
Yeah, Proteus. Okay, Proteus.
Yeah.
And start with a K. What a K?
Yes.
What is K? Tell me the name. Klebsiella. Okay. Klebsiella. Okay, and another one, S. What is S?
Staphylococcus.
Okay, Staphylococcus. Okay. All right. Good. All right. So I want Tan Bùi. Tell me, what does nitrate positive mean? What does this mean? What bacteria tell me that it's a nitrate test is positive? Okay. You guys go to the hospital all the time, right? You see leukocyte positive, nitrate positive. Like, what in your head? What does it mean in your head? You can't just order the test. Doesn't mean anything. Okay.
Yeah. It means that there may be the existence of the gram-negative bacteria that let's make nitrate to nitrate, but I forgot the name.
Okay, so there's one bacteria that I'm only interested about one bacteria that this test will tell me. All right. Anyone else know the answer? All right, if it's nitrate positive, what does that mean? What bacteria might be in the urine?
E. coli.
Wow, see, exactly. That's what I mean, right? So if you have nitrate test positive, most likely it's gonna be E. coli. All right. So that's why when you order the test, you have to understand. So leukocyte esterate means that you have some white blood cell in the urine. That means you have some sort of infection, right? If it's a nitrate positive test, yeah, maybe it's some E. coli. So next time you go into the hospital, you see the old folks, right? You do the UA, and then it come back leukocyte positive, nitrate positive. Most likely it's E. coli. And if it's Uric positive test, and you think about protease, Klebsiella, Staphylococcus. All right. So that's what it all means, basically. Okay. So reduction of urinary nitrates, bacteria, most likely is E. coli. Again, leukocyte, evidence of white blood cell activities, okay? Yeah, so remember leukocyte means white blood cell, all right? All right, so number 4, a 33 years old professional basketball player is brought to the emergency department because of intermittent excruciating pain in the right flank. The radius is inner thigh and testicle. The pain is accompanied by nausea, vomiting. Physical examinations show that he has negative rebound tenderness, but Garden is present, as well as dysuria and hematuria, urine crystal envelope, and dumbbell shape. Which one is the most likely diagnosis? Okay. All right. Sorry, I'm running out of breath. I screamed too much last night. Let's see, Tan Bùi. I'm gonna have you answer this question. What do you think the patient has?
I think D or D.
Okay, good. So what tell you that he have a kidney stone? What symptoms?
He got dysuria and hematuria.
Okay, so hematuria is more specific for kidney stone. Okay, what does this tell here? Urine crystal, right?
Yeah.
Yeah, so envelope and dumbbell shape.
Dumbbell shape.
Okay. All right, let's say in the test, right, you come down to C and D, right? You're right. All the others we're going to talk about later, but you come down to C and D, and you have no freaking idea which one is which, right? You should pick what is the most common, right?
Yeah.
If you have no idea, always go for the most common one. D.
Yeah, D is more common.
What is the most common stone?
Calcium, and it's a radiopike.
Yeah, but calcium, there's 2 calcium. Calcium oxalate or calcium phosphate. Which one? You're right. I mean, both of them are going to be opaque because have calcium in it. But most common is calcium what? Oxalate
calcium
or
oxalate.
Okay, oxalate. Great. So remember, if you're on exam, you have no freaking idea this, always pick the most common disease, okay?
Yeah.
Okay, so that's the trick. All right, so, all right, tell me what biliary colic means. What does biliary colic tell you? What condition that you have biliary colic?
In cholangitis?
No, cholangitis, I tell you, that's infection, right?
Oh, yeah.
And did any one of you guys go to my lecture last time?
Yeah.
Okay, so let's go. Okay, first one, you have a gallstone, right?
Cholecystitis.
Okay, gallstone is chole. No, gallstone is not cholecystitis. Gallstone is chole. Remember, chole is gallstone, right?
Lithiasis.
Lithiasis mean it's a stone. Okay, so chole, lithiasis, so it's a stone. So usually this will happen when you have biliary colic. Okay, mean that it's it's sort of like come and go. Okay, so if you have constant pain, right, a little bit of fever, right, and a little bit of like white blood cell. What is condition? What's the next condition? If the stone got stuck in a, so I'm telling you now, the gallstone got stuck in the cystic duct. It got stuck.
Cholecystitis.
Exactly. So yeah. So remember, break it down. Cholecystitis, right? Right. Cystitis means it's an inflammation of the cystic duct. Okay.
Yes.
Yeah. So and then after that, if the stone moved down to the common bile duct, what do you get? So now you got gallstone, and then we have the common bile duct. Okay. What do you get? Chole, right? Chole, which is what? Which is a bile, right? Chole, what is a common bile duct? Doco, right? Lithiasis, exactly. Yeah. So remember, choledoco means that is a common bile duct. Okay? Yeah, lithiasis means a stone. So you have a stone and a common bile duct. And what symptom do you have for this one?
Jaundice.
Yeah, so it involves the liver, right? Involve the liver. Okay, so that's why you have jaundice. You have elevated. Sometimes you can have also elevated white blood cell, liver fever, right upper quadrant pain. All right, now you have ascending cholangitis, right? And now you have the inflammation of the whole system, the whole biliary system. So now you have the triad. Remember the triad? Charcot triad. Okay, what is the symptom of Charcot triad?
Right upper quadrant.
Right upper quadrant pain. Right upper quadrant pain. Jaundice. Okay.
Fever and jaundice.
Exactly. Okay. Now I want you to tell me the pentat. Now you want the pentat.
Mental status and hypertension.
Yep. So you have sepsis, right? Sepsis. Just remember, sepsis means that is low blood pressures or hypertension and altered mental status. Okay. Altered mental status. See, that's all you need to know for gallstone. Right? If you know all that, you will know everything about gallstone. Okay. So what does cystitis mean?
The inflammation of the bladder.
Exactly. So what symptom you have when you have cystitis?
Yeah, hematuria, dysuria.
Yeah, so dysuria, not hematuria, but more like dysuria, increase in frequency, right? Like urge, you have like you have the urge to go to the bathroom, and you go to the bathroom more often, so it's frequency. So it's dysuria, urgency, and then frequency. Okay. And what about testicular torsions? What does testicular torsion means?
Yeah, it's the torsion of the blood supply to the
exactly. Okay, so you have like acute pain, excruciation pain, right? And you shouldn't have any urine crystal, but when you do the test, the Christmaster reflex test, when you touch the side of the thigh, their testicle doesn't arise, at the same level. One of them will be higher than the other. Okay, That's why they call it the high riding testicles. All right. So hopefully you guys learned something, useful today. It's a long lectures because there's a lot of them. But like I say, most of the time people will test you what kind of stone they are and the dietary prevention. Okay. All right. Then I will keep asking you the stuff about the gallstone because, it's so simple, but you just have to remember them. Okay. All right. Anyone have any more questions? I'm sorry that my voice is not very clear today because, I screamed a lot last night watching the game. So I hope you guys all watched the game because, when I lived in Vietnam for 10 years, we never won anything. But when I came over here, we won it. Last time we played against, I think it was Philippines, we lost. I was so mad, but, we won this time. So, all right. So I hope you guys have fun with these lectures. Hopefully it's helpful. Next time we're going to try something a little bit newer. Do you guys know osmosis videos?
Yes.
Yeah. Sorry. I want to answer. So,
yeah. Sure.
Yeah. In the question 3.
Yeah.
Through hypertension.
Yeah.
Through hypertension, you say it's so it's a hypertension stone.
Okay, so let's go. Question number 2, right?
Yes.
Okay. So hypertension's so it doesn't affect the macro structures. So it doesn't really affect the renal calyces or any of these structures. It affects the micro structures, which I mean is the the afferent vessel, right? The glomerulus, right?
Yeah.
And then you have the efferent vessel. So when you have hypertension, your blood vessel become thicker and the glomerulus start to change, okay? So you only see micro changes. You don't see macro. So we call it micro. Let me type it. Okay, so hypertension or diabetes, okay? Only affect the microstructure. You can't see it by eyes, okay? Microstructure.
Yes.
Yeah, only the glomerulus. You can't see the glomerulus, okay? Right?
Yeah.
So that's the only reason why you cannot see this disease that causes this problem. Okay?
Yes.
Yeah.
Yeah, I can see the answer E here.
Yeah. Okay, all right. So tell me what is interstitial nephritis? What you see on interstitial nephritis?
Yeah, I remember that the drugs is methicillin, right?
Mm-hmm. Penicillin, great. What symptom do you have?
Yeah, you have presence of the white blood cell in the urine.
So you say white blood cell?
Yeah.
Okay. And what else you see?
A rash.
Yeah. Okay. So when I think of interstitial nephritis, we call it acute interstitial nephritis, right? So I think about allergic reaction. Okay. So when you have allergic reaction, what do you see? You see rash, right? Right? Yeah. See rash, and then you have acute kidney failure. And then when you do a UA, you will see, a white blood cell, and then you also see eosinophil.
But not the bacteria.
Right? Yeah, no bacteria. So eosinophil. So absolutely, you have to see eosinophil and white blood cell to cause acute interstitial nephritis. And like you say, all the P, like penicillin can cause it. There's a list, but penicillin come to my mind the first. And also, I think acetaminophen can also cause it too, but not very common. And PPI, all the P drugs, rifampin, okay, so you have to remember that. Okay, so white blood cell and eosinophil. But usually you have to have a rash because of allergic reactions. All right, anyone else have any questions? No? Okay. It's fun. Let's go back to osmosis. You guys familiar with osmosis?
Yes.
Okay. So my plan for the future is that I want to help someone to translate, osmosis video into Vietnamese. So before any topics I give you guys, I think osmosis video is very helpful. Okay. So it's like introductions for you guys to understand a little bit. So I'm gonna put a post on Facebook, and hopefully you can go to like YouTube and translate it correctly directly. So let me show you like here.
Yes.
Okay, let me show you that you can actually translate osmosis. All right. All right, so osmosis. All right. All right, so okay,